This week on the BackTable podcast.
When the surveys come in your inbox, just fill them out. Because if we have 200 of them instead of 30 of them, it's hard to deny what we're requesting. If we have 31 and we needed to have 30, we're flimsy. And so just accurately answer the survey based on your opinion on how the procedure is. I'm not saying to, don't try to just puff it up. Just look at the comparator codes and say where you think this procedure falls. And the more data we have, the more likely we are to be able to preserve what we're getting for the work that we do.
I'm your host, Sabeen Dhand, and today we're diving into a topic that affects every RVU you earn, but rarely gets talked about, the RVS Update Committee, or RUC. We've brought together two fantastic guests, a radiation oncologist, Dr. Amar Rewari, and Dr. Curtis Anderson, an interventional radiologist, both with firsthand experience on the RUC and both deeply involved in advocacy. Welcome, guys.
Thank you. Thanks very much.
Today, we're going to talk about how the RUC works, what makes it tick, why endovascular specialists should really be paying closer attention to everything that's going on. But fun fact, Dr. Rewari, he runs a great podcast focused on healthcare policies called Voices. It's really great. I've listened to it, and we're happy to collaborate on this episode with him and his platform and talk more about it later throughout the episode. Tell us just a little bit. Let's start with you, Amar. Where are you from? How long have you been in practice? And then we'll go to you, Curtis.
Yeah, thanks, Sabeen. Thanks for having me on. I'm in Annapolis, Maryland, working as a radiation oncologist out there, and I've been our RUC advisor for our American Society for Radiation Oncology now for almost a decade, I guess, going to the RUC meetings. And then thank you for the shout out to the podcast. It is called Value Health Voices for our listeners and viewers. Thanks.
Got it. Yeah. Curtis, what about you?
As I said, I'm an interventional radiologist in South Florida and finished training in 2013 and started getting involved with the RUC not too long after that, mostly on a part of the RUC that we'll talk about called practice expense, which is how we figure out how much we get paid for procedures that are done outside of the hospital. I became the RUC official RUC advisor or assistant advisor and then advisor in around 2015. So I've been doing it around 10 years, first for SIR and now for OEIS.
So, okay, I mean, either of you can pick this up, but can you briefly explain what the RUC is and why does it matter to us practicing physicians, especially in procedural heavy fields?
So the RUC is a committee that sits with the AMA that's been tasked with assigning valuation for CPT codes. So CPT codes are all our procedural codes, as everyone knows. So the codes get created in the CPT committee and then eventually make their way through to the RUC, as I'm sure we'll talk about more in the episode. But the RUC has delegates who sit on the committee who are from different specialties, but they no longer represent their specialty. They are supposed to be impartial, independent, and not like an advocate for, let's say, interventional radiology or radiation oncology. And then it's at the RUC where they look at certain components to value codes. So they look at physician work, and they look at practice expense. And for practice expense, they look at direct and indirect practice expense. And for physician work, they look at the time and intensity of that work.
Okay. And then, I mean, how many people are on the RUC?
I think it's around 30. Curtis, do you know the exact number?
It's something like that. It's in the 30s. And some are longstanding members and some are rotating members. And they do represent all the surgical and non-surgical specialties. They represent physical therapy and podiatry. And so they really cover the whole gamut of medicine.
And yeah, I mean, that's interesting how, okay, so you don't represent, I actually assume that you're representing your specialty and then bringing that information.
No, we do. Yeah. So the panel is this panel of experts that are on the RUC panel. And then when a code that involves your specialty and it's sent out as a letter, and if you think it's something that your specialty is involved in, then you join with other specialties that are also performing that procedure. A good example would be, let's say, bone biopsy. You have podiatry, you have ortho, you have different specialties, obviously radiology. And so we all sign in, we work together to then advocate for the value of that code as it's presented to the RUC. And so this is something that happens 3 times a year. The RUC is part of the AMA. Not everybody knows, but the AMA owns CPT. The CPT code system is owned by the AMA and licensed to CMS for billing purposes. So that book, the CPT book, that big Bible of a book, that's owned by the AMA and distributed by the AMA.
Yeah, and so like every professional society has their own RUC advisor who represents that specialty or society. So Curtis, like he said, is his specialty's RUC advisor, and I'm my specialty society's RUC advisor for radiation oncology. But we advocate for the specialty to the RUC panel of those experts.
I get it. Okay. And then, I mean, you said all specialties within the 30 people is basically represented between those 30 people on the RUC committee or on the advisors or explain that, because I'm just trying to get it all.
The largest specialties all have a delegate assigned to that specialty on the RUC panel, but they are supposed to be independent, no longer represent their specialty. So thoracic surgery, a lot of surgical specialties will have somebody. Radiology has somebody on there, but radiation oncology does not. So there's also rotating seats. So somebody who's not in a specialty that's normally represented on there can also be on that panel.
And I think it might be kind of useful to literally kind of just go through like what would a new CPT code is presented, and can it kind of walk us through like how does this work, where does it start, and how long does it take to determine that work RVU that's associated with that CPT. So Curtis, I don't know if you want to maybe give an example. You give bone biopsy, or a lot of our listeners, may want to talk about like an angiogram with intervention. What would you do for like a new code such as intravascular lithotripsy?
Right. So let's talk about something that's completely new. Let's say there's a new type of ablation, right? So if you have a new modality of ablation that is coming out, it's never existed before. We've never had a mechanism to pay for it. So a CPT code is created, and that's a whole separate process that often we're involved with as well. So I'm involved with that as well. But once that code gets approved as a code, it gets kicked over to the RUC process. And so, as I said, a letter is sent out to all the specialty societies, and they can choose whether to sign on. And then the job of each society then is to survey their members. So they send out surveys to their members, and the survey is created in partnership with part of the RUC process. And it's meant to gauge the community of your members in your society and figure out how much time it takes to do all the aspects of the procedure, how intense the procedure is, and how it compares to existing codes. So a lot of the work that we do is really framing out the comparator codes so that the members of our society, when they receive a survey, can sort of share the relative amount of work that it would take to do this new procedure compared to something that's already valued in the code set. So that's the surveys that get sent out. And with that, you get a time associated with each component part of the procedure, the workup beforehand, the actual procedure itself, the follow-up afterwards, and then the intensity of it relative to these other procedures. And so that's all in the survey itself. And then the advisors, all working together, will also work on the practice expense part. So you literally go through and account for every minute of every staff member that you're using in your office if you're doing this procedure in an office setting, and also every single piece of equipment and every single supply item, whether it's a piece of gauze, whether it's a shoe cover, whether it's some betadine in a little bowl. And so you're accounting for every single item, and you have to be able to justify that both in the report that we send before the meeting, but then when we present everything to the RUC, the data from the surveys and the data from our practice expense, we have to be able to justify everything within the existing code set that's there.
And Amar, like, how do you guys handle? I'm sure there's going to be disagreements about what people think. Is it pretty much everyone agrees and tries to push for the most work, RV? Like, how does it, like, what's the dynamic?
It's like Game of Thrones. That's the way I describe it. So like,
Yeah.
you're in a hot seat. It's like giving congressional testimony,
Oh, God.
you're in a hot seat. There's this whole panel around you, and they can grill you with as many questions as they want on what you've submitted from your survey data. And they're ruthless, and
Really?
because they have to be, because it looks down to every little penny. So they'll say, do you really need one pair of gloves, or do you need two pair of gloves? Do you need one gown for this procedure or two gowns? Can you use a regular patient table, or do you need a motorized table? Because all these things cost money, right? So for the practice expense side, they'll look into that much depth. And if they're not happy with your answers, they can, make you like agree with them. It's kind of forcibly agreeing with them, because otherwise you have to kind of redo it all again, right?
Yeah.
And so you have to discuss with your partners at the table real quick to decide, are we going to like take a compromise, or are we going to, fight it out? And then on the physician work side, same thing. There's a lot of, because they'll say, well, is this really that intense? And to think about intensity, I think one way to think about it is that, let's say if you're doing surgery on a spine, right? That's a very intense procedure versus if you're maybe treating a child with a cold or something, so there's like different levels of intensity, right? Because there's stress associated with it. And so when they look at the comparative codes you submitted, they'll be like, is this really that intense? And they use this acronym called IWPUT, which is intensity work per unit time. And that's the ratio they're looking at. And they look at that versus all these other codes out there, and they'll say, really, is your IWPUT the same as neurosurgeries or radiologies and what have you? So it can be very stressful, because millions and millions of dollars are on the line for our specialty in terms of reimbursement just from these conversations.
Interesting. That's I'm glad that there's some of this non-tangible, stress that goes into the, determining the ratio of how much it should be. I guess, Curtis, like, how would you say, like, a visceral angiogram with embolization could be some outpatient that you're embolizing something completely elective, versus this crashing GI bleed where there's a lot more stress involved? How do you differentiate between those two CPT codes?
Well, that's part of the difficulty, is that there really is no way to differentiate between the same embolization in the same surgical field, same bed. So it's the same procedure from a CPT code standpoint. Way it's done now with work on the work side, it's wherever the most prevalent setting is, whatever the most typical scenario is. And still, for something like arterial embolization for bleed, that has a specific code for it. If you're doing that for a slow bleeding prostate, it's going to be the same code as it would be for a GI bleed. But the most typical use for that code would be a bleeding trauma patient or a bleeding GI bleed. And so the work is valued based on that typical patient. And we actually create a vignette, a story that is the typical patient, and that is what is discussed. And so, all of this is really stressful, because also you're talking with physicians whose work is primarily cognitive, right? So you have internal medicine physicians that are not doing procedures.
Yeah.
And frequently their intensity per unit time and therefore your RVUs per unit time are less. And as you would, if you were an internal medicine physician, you would take some level of umbrage to that, and it doesn't make you so happy. And so they could get contentious. They can get really contentious. And so that's what we're doing every time we go there. And you build, I think Amar and I started almost the same time. So you build a reputation as being a reasonable person in the process, and you try to maintain that reputation, so that, because in the end, there's a finite amount of money, right? So if your set of procedures goes up, that comes out of that pool. We have budget neutrality. We have a limited set of money. It doesn't ever go up, right? It actually goes down, right? And so if all of a sudden a new procedure comes out that costs a lot to the fee schedule, that means every other physician not doing that procedure is taking a few pennies less per minute. And so it is contentious. It really is.
It's fun. Yeah, I can just imagine. You don't have to name names, Omar, but do people like hate each other? Some people, or is it like
I don't say people
not hate
hate each
is a
other.
bad word,
I mean,
but
definitely some societies, there's some kind of politics around that, as you can imagine. So If we're kind of, I mean, it's not turf wars, but at the same token, I mean, there can be overlap between different specialties. And so depending on what code is up, there can be, mixed incentives, right?
Like, and what about like informal power dynamics and unwritten rules? Like someone who's been there for longer, do they have like more say, or is there any kind of like, or is it really remain quite objective for even someone who's new and starting?
It's supposed to be objective. So I will say that I personally have not noticed anything, but I was also fortunate that when I first started, there wasn't a lot of stuff in radiation oncology that was being brought forward. So I was able to just sit back, observe, and learn. I think it would have been really tough for me to go to the table right off the bat, in the first year without having had that experience just observing and listening.
So over the last several years, how have you seen your role in representing radiation oncology change? Like, how has it matured?
No, it's more just that it's all what is coming before the panel. And so I think in recent years, there's just been a lot more radiation oncology stuff coming before the panel, which has required us to be much more obviously involved in the process, as opposed to if there's not stuff going on for radiation oncology, we can just sit back and watch Curtis deal with all the radiology stuff and interventional radiology stuff.
We definitely find ourselves at the table probably more than most specialties. I would say radiology definitely, and then interventional we're there a lot.
I'm sure. I mean, IR can sometimes be young and stand alone. Does that affect any kind of leverage or influence at the RUC, or do other specialties like cardiology and vascular surgery, is it a pretty unified experience?
Well, I've been working with those specialties really since I started. And a lot of the codes that we do, we work closely with Society of Vascular Surgery and with cardiology, both SCI. So yeah, we work with them all really closely. None of the sort of turf wars that we experience out in practice occur in there because we help each other. And I don't find that when we're on codes together, at least with the endovascular societies, we have really any issues from that. It's more just that in medicine, we're doing medicine, right? So there's usually a pretty good idea what's right and wrong, what we're doing all day. We're trying to take care of patients. It's pretty clear. At this interaction is a human interaction, right? So it's going to have all sorts of relationships and politics. And some people are trying to improve their career by moving up in the AMA, or other people are trying to improve their way up their society. And so it's totally different than what I do every day. And I think that's actually what drew me in, to be honest, because I'm learning and it's almost all this psychology. And it's a little surreal because it's like IWPUT. There are other acronyms and calculations and factors that go into everything. And so you're always trying to figure out how everything you do impacts all the other things down the line. So it's interesting. It's a fascinating process.
I bet. I mean, Amar, is there any kind of notable like wins or losses that you've kind of gone through in the last 2 years on the committee?
Well, that's the problem about this. So this is a good way to bring this up, so that there's a lot of work that Curtis and I do and the entire team that works with us, for the society on the RUC stuff. And I mean, hundreds of hours worth of work, right? And the problem is with the RUC, it's all confidential. So nobody knows your wins. You'll celebrate with your little team at the meeting and feel so grateful because a win doesn't mean that you get more money. It means you're not getting cut, right? And so for the most of the membership and most like people who are practicing, they only see if there's cuts, right? And so they only know your losses. They don't know your wins. And so you never get credit for the good stuff. You only get blamed for the bad stuff. So it's a little bit of a thankless, and it's a volunteer position, right? So this is not something that you get compensated for. So
it's a lot of work. Yeah, voluntary, thankless job. Would love to know the wins and be able to do that.
Yeah, so the process is confidential, which I think protects a lot of the work that we do. So I understand why it has to be confidential, because we go through a lot of conversations and a lot of hard work, and a lot of stuff is ongoing that would affect industry and decisions in healthcare that maybe somebody could take advantage of. So it has to be confidential. Everything is recorded and all of the sessions are stored, and CMS actually has representatives at the table and are involved in some of the discussions that we have at the RUC. So it is a direct conversation between the AMA and all the RUC panel members and members of CMS, which in its own way is a little bit of a difficult conversation to have, because dealing with CMS, you have to have even a little bit more deference and concern than you would at one person who's volunteering at the AMA at the RUC table, so.
Oh, yeah.
It's
I don't know.
pressure.
I'm just imagining, like, now you mentioned the congressional hearings, and I'm just imagining all the news that I watch these days, and your guys' panel and everything is like that. I don't know. It's a pretty.
I mean, I've definitely had people get heated at the table. I can just say that. And you have to keep your calm. You have to keep very cool, be very professional.
I don't think I would do well on the committee, so don't worry, I will not.
I only got yelled at
I could
once.
get heated.
Yeah.
I could get heated.
I got yelled at one time by somebody at the RUC, but
Oh man. Oh, good for keeping your cool, I bet. But okay, so a little spin. Let's talk base again. We're talking about, as general, about policies and advocacy and healthcare policies and economics, a little kind of leeway to your podcast, Value Health Voices. Tell us a little bit more about that, and did your experience with RUC kind of make you decide to start your podcast, or other way around?
No, that's a great question. Yeah. So because, as we were talking about, like, a lot of this stuff is not only goes unrecognized, but people don't really know what goes on behind the scenes. And then there's other people out there who are putting stuff on social media, either complaining about issues around reimbursement or healthcare policy without really understanding the nuances, and just kind of creates this false narrative and fake news, right? And so seeing that, I kind of wanted to correct the narrative and really put out accurate information. So the podcast is focused on healthcare policy, healthcare economics. We put it out once every 2 weeks, and the topics range from anything from prior authorization, right, which is stuff we all have to deal with, getting authorization for our procedures, Medicare Advantage plans, AI, physician reimbursement, what have you. So it's all different topics in that sphere. And so it's really good for people who want to learn more, who are either providers, such as like young physicians coming in, or physicians who are looking to work with their hospital administration, or people within the administration side who also want to learn more about it. And we have guests come on who are experts in the industry. Like, we had a guest on recently who was able to speak to a lot of the stuff going on in this administration around Medicaid and HHS and NIH and DOGE, and how that would impact healthcare. So Value Health Voices, and it's on all the streaming platforms and YouTube. So
yeah,
very cool.
Good. It's true. Healthcare policy is pretty, sometimes, I guess, people complain of the lack of transparency. Even for RUC, is there any lack of transparency? I know that the things have to be confidential. Could it be more transparent for others to know what's going on and see how all of this works in the background?
I think there's some information available, through the AMA website for people to learn more about how the process works. I think what you can't really know is what's being discussed at the time that it's being discussed, which codes are being discussed, what the outcome is of a proposal at the time, at one of the meetings before the actual CMS rules come out.
Okay.
Yeah, and I think what's really important is for all the physicians out there that from every society that might watch this podcast, is when these surveys are sent to you, you should fill them out honestly. Sometimes the difficulty that we have is we have thresholds of how many surveys we need to get in order to be a valid survey so that we can go and petition for a value at the RUC. And it may be 30 results, and we send it to 500, 800 members of a society, and we get 30 back.
Yep.
35.
Your classic people not responding to things, just like,
and those are the ones who are oftentimes complaining about the cuts.
Yeah.
But they don't want to fill out the survey and give us information so we can fight on their behalf.
That's huge information. We'll spotlight that too for this episode, because I may have ignored one of those once or twice too. There's so much that's going on. And then what about, everything changing to bundled payments and value-based care? Is there going to be any kind of RUC's shift of their role in the next 5 to 10 years that you can think of that would go in line with that? Or is that just...
Yeah, I mean, that's a really good question because, with this new administration, in the past, RFK Jr. has made comments about, not feeling more like that the RUC may be not the best way to value things and going to more value-based care might be a better approach. And so it'll be interesting to see what happens in these next few years with him and Dr. Oz, if he gets confirmed in those key positions. I will say in radiation oncology, we just have legislation that was introduced last week for a new payment system for our society that is a bundled payment. For each disease site, there'd be a fixed payment paid out, a technical payment and a professional payment. And it would be mandatory for every radiation oncologist in the entire country. And it's because, the worry is with this RUC system, the way it functions, with budget neutrality, it's a race to the bottom. And so it doesn't value, because you can't expand the pot, it's very difficult to value emerging technology, right? So having maybe a fixed bundle payment might at least stabilize payments, and then new technology can come in through the RUC process. That's what we are proposing, and we have bipartisan support in Senate and House. So we're going to try to hopefully get it attached to a bill. ACR has signed on to it for those listeners, and as well as our society, Astro, and a lot of the other societies. So we're hoping.
I mean, new technologies, speak about AI and all the development that's going on now. I'm sure all these digital health tools are something that's going to play a role too in the discussions with RUC and different CPT codes. Has any of that come up yet or thought about?
It is on the radiology side. Obviously, AI has been around for a while for lesion detection in imaging. And obviously, it's a battle, right? It sounds like it makes your job easier, but in the reality of it, it may make the outcomes slightly better, but it doesn't necessarily right now make anything easier. If anything, it may make things a little bit harder. And then there are costs associated with implementing all of these things.
Yeah.
And so we have to be able to accurately capture all of that. Whereas, the initial tendency may be, reading a CT scan with nodule detection is easier, right? Rather than harder. But, if I have an imaging center, I have to implement that everywhere. And then I have to have people checking and make sure it's functioning right. And so it's not necessarily as simple as you might think.
Yeah. No, I can imagine. I mean, I feel that there's so much more that's going to be coming out. And I mean, do you guys foresee yourself, staying on, putting hundreds of more hours in? I mean, what's your kind of goal, if you can think of, in the RUC? I mean, where do you guys foresee yourself in 5 years?
Curtis, you go ahead first.
I'm still on the fence with that. I mean, I've done a pretty good job of nefariously recruiting people into the societies to replace me as I go through so that I can sail off into the sunset pretty soon. But at the same time, it takes years to even understand the process. I mean, I really was, as Amar said, it was 2 to 3 years before I even understood what anybody's really talking about. And then the level of nuance and politics underneath it. And so when you build a reputation, you understand the process and you can finally catch your stride in it, it doesn't make as much sense to stop doing it, even if it's a burden to a certain amount of time. So I'm still on the fence about it, to be honest.
I'm also on the fence. I mean, just like Curtis, I'm bringing in younger people who hopefully will get trained and up to speed. So if I do want to sunset off of it, I'll feel like the specialty is in good hands, but we shall see. Yeah.
Yeah. I mean, and someone who maybe be listening right now and they're like, oh, they really are interested in this. I mean, how would they even get started? Or would they just reach out to you guys or reach out to RUC? How does it work?
It's usually through the societies. So when I was with SIR, you'd reach out through economics. The CPT RUC committee is a part of the healthcare economics subcommittee of SIR. For OEIS, it's a small society, and so you just text me or whatever, email me, or Jerry Nidzwicki, who's the other advisor. But yeah, I think it's just through the societies.
Got it. Amar, same thing for you.
Yeah,
for
exactly.
Right
Yeah, it's through the societies. The other thing we have, which we'd started back in 2015, was a fellowship. So we have a 1-year fellowship so people can apply a health policy fellowship. And through that 1 year, we kind of give them a crash course, teach them like monthly calls, have them attend the meetings. And so this way they could kind of learn more about it. I'd say many of our fellows, though, after the year are like, bye, see ya, sayonara. I'm not doing this.
Yeah.
So the retention rate of our fellows is very low.
Sure. I mean, you got to have a passion for it. You guys obviously do. I give mad kudos to both of you. It's something I'm so grateful for all of the work and the hours that you guys volunteer to do this. Well, I know there's a deep dive and I think it's clear, while the RUC might feel distant and from day-to-day practice, I mean, it's the foundation of how we're valued and how new codes and new procedures, I mean, in both our fields, we get so much advancement every year that new CPT codes are going to be coming everywhere. Any kind of parting words of wisdom? I know we mentioned just now, like how to get involved, but anything else, the best thing you've learned in RUC or wish someone else would know before getting started?
Answer your surveys. When the surveys come in your inbox, just fill them out. Because if we have 200 of them instead of 30 of them, it's hard to deny what we're requesting. If we have 31 and we needed to have 30, we're flimsy. And so just accurately answer the survey based on your opinion on how the procedure is. I'm not saying to, don't try to just puff it up. Just look at the comparator codes and say where you think this procedure falls. And the more data we have, the more likely we are to be able to preserve what we're getting for the work that we do.
Yeah, and the only thing I would add is like if you're feeling frustrated about cuts and reimbursement, to definitely know that there's people who are doing all this work behind the scenes. So contact your society and they can definitely put you in touch with the people on the economics committee so you can get more involved or at least understand more about it. And tune in to our podcast, Value Health Voices, to learn more.
Amazing. I don't know. I had this one question. Maybe we'll cut it out depending upon what we answer. But who else should be paying their AMA dues? Because I haven't for a long time.
So if you fall below a certain threshold of a society membership that is part of the AMA, you get kicked off the RUC process.
That's crazy. So, but if you are already supplying like SIR, if I'm paying for them, is that being counted?
No, a certain percentage of SIR has to be member of AMA in order for you to be part of the House of Delegates and to be a member on there.
Honestly, I don't know anyone that I know that is paying. Like I actually just had this conversation not too long ago, but a lot of us are like, who's paying AMA dues?
Yeah, well, obviously we do.
But,
yeah. But it's extremely important.
Do IRs know that? I mean, that to be paying.
I don't think physicians know that in
Yeah,
general.
I don't even know what I don't even know what that percentage is.
I don't think people know. I mean, AMA is something I paid when I was in med school.
As far as OEIS, that was the way that was a threshold we had to meet to be on the House of Delegates. It took a while, and advocacy to get the membership to join. Particularly if you're mostly outpatient, you might feel kind of removed from institutional medicine, and maybe you think AMA is not really something that helps you, but to be part of this process that decides the evaluation,
It's an important process.
you've got to have enough members, and so it's an obligation really for at least a certain number of members to be in the AMA.
Yeah. Oh, I'll start paying. Well, a big thank you to you guys for pulling back this curtain. It was all new to me, trying to learn what the RUC is. And, to all our listeners, I mean, if you want to be a part of this or not, just be reactionary and get, annoyed when there's a cut or something you're not happy about, I mean, and get involved, right? Like get involved. The representation starts with all of us. You guys are doing the hard work, but we need to be a part of that. So stay informed, get involved, keep innovating. Guys, thank you so much. Like it was really a pleasure having you guys on.
Thank you.
Thanks, Sabeen.
Thank you so much for listening. If you haven't already, make sure to subscribe and follow rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, or Blue Sky. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabeen Dhand, Michael Barraza,
and Ali Behetti.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Bagrizio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again. See you next time.